Hello, and welcome to today's episode of the podcast. I'm Christine. I'm a physical therapist and the creator of Aging with Ability. And I just want to talk today about physical therapy and how it is a treatment option in itself. So, along the way with my history as a physical therapist, especially an outpatient, I had people come to me as a patient and they would say something like, my doctor sent me here. I'm here waiting so I can have surgery. They won't give me an MRI until I've been with you for 8 weeks. Kind of statements like that, which I love that they're being totally upfront about how they got there. And I always want to know kind of what their past history with physical therapy is, or what they were told about it before they got to me, just so we can start on the same page, or I can start to kind of educate people about what physical therapy is and what it does. So that's pretty common situation. And I just want to talk a little bit today about how walking in with that attitude can kind of take away from some of the benefits of physical therapy. And maybe you're sitting there listening to this and thinking about how you have that physical therapy referral, but you're really looking to get that, knee MRI or hip MRI, and you just want to have surgery. But maybe I can change your perspective a little bit today. So let's first just kind of talk about the benefits of physical therapy compared to surgery just as a whole. So one of the biggest things about it, and what I love about being a physical therapist, is I am completely non-invasive. Yes, there are physical therapists that do dry needling, but that's as close to, breaking skin as they're going to get. So there's really, really, really limited infection risk. Of course, they need to be taking sanitary precautions in the clinic or environment that you're having therapy in. But other than that, it's not like a surgery where you're being cut open, you're being in the hospital, you're being in that environment, and the potential for infection is a lot higher. So that's one benefit for sure. Just kind of that non-invasive, less risky. The other one is it's definitely typically cheaper. So most insurances cover physical therapy fairly well. Sometimes there's, $30, $35 copay, depends on where you want to go. A lot of cash pay physical therapists exist now just because the insurance model is so limiting and getting tighter and tighter and tighter on reimbursements. So in order to provide time one-on-one with their patients, or provide, better equipment and resources as a clinic, and not have to have someone on the phone with insurance companies so much, there are a lot of therapists moving into that cash pay model. But as a whole, it is typically cheaper. I mean, even if you're paying $150 a visit, you are saving a lot of money based upon that $5,000 deductible or whatever you might have to pay to have surgery. You're also going to be taking less time away from work or other activities that you have going on in your life. So that's another way where you're really gaining back some of that time and that freedom and, money and resources. One of the examples we'll discuss in a little bit, one of the studies, they show twice a week for 6 weeks of physical therapy, which, about an hour per visit is the, kind of standard. So that's really 12 hours of your time, plus getting to and from the clinic and doing some of your home exercises. But, giving that timeline, that's 12 hours. That's half of one day over a 6-week period of time. And that was shown to be beneficial. So again, we'll get into that sample later, but I just wanted to kind of give you a little bit of a time frame, that versus 2 weeks out of work, 5 months or whatever it is, recovering fully and getting back where you were. The other thing is that it really helps to make physical changes to your tissue under your own power. So you're not having this outside force come in and be doing those changes, and then you have to recover from that all at once. It's a more gradual process where we're lengthening tissues, we're changing your strength, we're increasing range of motion, and you're actively involved in that process and learning about how these restrictions and weaknesses that we identify as part of our eval are impacting you and the way you move. And then the other thing is it can be modified over the course of treatment. Something may not be working as quickly or as well as we wanted it to. We change it, we try something else, we add resistance, we take it away, we maybe add a modality, maybe you've never used e-stim or heat or ice, and we can educate you about that. And kind of going along with that too is physical therapists are really built for teaching patients about like lifestyle changes, healthy habits. People may not realize that we talk to our patients a lot about like sleep, hydration, alternative pain management, again, kind of back to those modalities, which, there's different beliefs about how helpful they are, but they do play a role. And again, like weight loss, exercise, sleep, these are all things that your orthopedic doctor is not as much of an expert in because they know things that I don't know about how to get in there and get the job done. But we get to spend more time with our patients too. And that's one of the things I love about being a physical therapist is I do get to see my patients, twice a week in outpatient or home health, up to 5 times a week in skilled nursing where I've worked. And so we build that relationship over time. It's not a quick pop into the office, see the doctor 20 minutes, talk about your x-ray, that type of relationship. So again, you get kind of a team member on your healthcare team that gets to partner with you over a longer period of time. And I think that has a lot of benefits. And that's where we dive deep and ask questions about, is your pain worse in the morning? Is there things that you do to make it better? Like, let's do more of that. Let's do less of this and team up with you. And also physical therapy can lead to the prevention of unnecessary tests, x-rays, MRIs, CT scans, they all have a role in looking at tissue and seeing what's going on. And especially if it is, something acute or traumatic or something severe, like, extensive numbness or loss of bladder and bowel function, like maybe some spinal issue going on. Those are, great tools that we have. And I love modern medicine for that, but they're not always necessary. There's been multiple studies and I'll find a link to one. I didn't look that one up before I started, but there's studies about, sending 100 people that are healthy and don't have back pain into an MRI, and they find like bulging discs, spinal stenosis, etc. So imaging results don't always correlate with clinical symptoms or issues with being mobile and things like that. And again, I could do a whole episode on that about how imaging has its role, but it's not always this A to B relationship with symptoms and how that person presents based on their findings. I have neck arthritis myself, maybe partly from a car accident I was in, but also just over time or whatever else. And I don't typically have neck pain. I did after my car accident, but those changes have still occurred in the tissues, but I'm not dealing with neck pain on a daily basis. So that's kind of where that correlation is. There was even a study about derby car drivers, which, they crash and crash and crash over and over again. And they looked at their pain level and their arthritis level from that kind of repeated damage over time. And they just don't fully correlate. So it isn't a perfect relationship. And that's important to know because a lot of times doctors also will say, you have bone on bone arthritis and kind of these doom and gloom terms that then as a physical therapist, I spend a lot of time educating people to learn what that really means and how that doesn't automatically mean that they're going to have pain for life. They're going to have surgery, things like that. Surgery has its place. And especially if you are looking at a joint replacement, in some ways it is better to do it younger. But again, that decision has a lot to it. And working with someone who knows you on a weekly basis can be a helpful person to put input into that decision as well. So a couple of kind of myths about therapy: that PT takes longer than surgery. That might be something people say is, oh, this is going to be weeks of therapy. I don't have time for this. But really what people don't realize is that surgery takes so much longer to recover from than they might think. So I cannot tell you how many times I've seen someone with a shoulder replacement, which is a very difficult surgery to recover from. And they think when that sling comes off at the 6 to 8 week mark, depending on the surgeon and the complexities about it, that they're going to be using that shoulder quite a bit. Once it's been immobilized that long, I had surgery myself on my shoulder for some instability, and you have a very weak shoulder at that point, and you've got a lot of fatigue, a lot of muscle atrophy from being immobilized. So it's a long road, and shoulders, I kind of tell patients about a year total. So you're not going to be spending 24 hours for a whole year dealing with physical therapy. You're going to spend, an hour twice a week, maybe in the clinic, and then 15, 20, 30 minutes, a day or 5 days a week doing some of your home exercises. and also participating in physical activity up at that, closer to the level of recommendation for adults. So this is not the 24/7, my shoulder is weak, I'm not going to get any improvement until a year. This is very different than a surgical recovery. And then the other one is just that myth about like needing those diagnostic images to tell what's going on. So physical therapists are musculoskeletal experts. We're very equipped with testing tissues, feeling them, doing range of motion testing. And again, I can't tell you how many times I've had a patient say, how did you know that was tight? How did you feel that? What is that, like? So we have a lot of hands-on history. We watch people move all the time. And so we know kind of what we're looking for, maybe some compensations you've been taking, like leaning more on one leg because you're trying to de-weight the other, or the one side is weaker, so you're taking a shorter step with the other because you don't want to stand on the painful one or the weak one long. So again, we really get to spend that time. I can't really stress that enough, that time is so important with someone who watches movement all the time. So I just want to go through a couple of case studies here just to kind of demonstrate the point a little bit more with actual reviews. This first one I thought was really great. So this was about lumbar spinal stenosis. So that means narrowing of the spinal canal in your low back. That's the lumbar part, is the low back. And then stenosis is a narrowing. I don't know, and you might have experienced this yourself. So where the spinal cord is, where those nerves are, that space should be nice and open, but a lot of times it can be narrow because of like bony deposits or something that's happened and causes narrowing. So this was a great study. So they were comparing people with surgery versus PT. And this was the one that I mentioned before that was twice a week for 6 weeks. And the therapy sessions had manual therapy, like massage, soft tissue, instrument assisted. It doesn't specify because it was all individually tailored, exercise, cycling, and body weight support, treadmill walking. So possibly a harness or something to help the patient be de-weighted to take kind of the pressure off the spine. I used to do a lot of times aquatic exercise. I worked at a clinic with a pool. And if people had lumbar pain, knee arthritis, hip arthritis, I would offer pool therapy sessions with them because of the buoyancy and helps kind of decompress a little bit. And then the surgery group underwent a decompression surgery, so opening up that spinal space, and then they had with or without a spinal fusion. So that's when they like attach a couple spinal levels together with like little bolts and metal. And this was a great study because they had an actual 1-year follow-up. So that's a nice timeline. And also all of them were over 50, and they did a really good job of like matching kind of timeline of symptoms, severity of symptoms, other clinical factors to the control group or the PT group and the surgery group. And they found that the people were doing about the same at the 1-year point. So again, some of those people underwent full-on surgery, had that surgical recovery, risks with anesthetic, infection risk, etc. And they really didn't come out any different than the people that went twice a week to therapy for 6 weeks. There was a note in that study that said they could have continued once a week for longer. And the surgery group had therapy after surgery too. So that was a great study. I liked that one. And then, maybe you're saying, I don't have back pain. What about an example for me? So another one I found was about shoulder pain, and this was in partial to full thickness rotator cuffs, and it was adults over 60. And they said that there was a 73 to 80% effective rate of conservative treatment, which was physical therapy in this study. And so that's amazing. I mean, that's so easy to see that you could be in that 72 to, 73 to 80% if you go the therapy route first. And that was with 12 weeks of therapy approximately. And they really encouraged like pain-free exercise. So going through a range of motion that was tolerable dependent on the symptoms. So that was a note that they put in there. And then kind of the final one I pulled was about knees. So osteoarthritis and meniscus tear. 70% of people went at least 6 months without surgery. There was a little bit shorter follow-up on that one. But again, 70%, big majority, going to therapy rather than surgery in this whole recovery. So I think that just kind of gives you a nice sample of therapy versus surgery. And again, surgery has its place, but the other thing about it is that physical therapy as a first choice treatment, which is why a lot of doctors send you there. It's not a waiting period. Yes, sometimes insurance requires certain things to be tried before they want to pay for surgery because, again, it is a really big expense. There are these risks of infection and also other things that you'll need afterward. So that's why you might feel like you're being sent to therapy, but it is a treatment in and of itself. And if you have a good therapist, you're going to build a relationship. They're going to get to know you over that course of time and spending that one-on-one time with you, educate you about different like habit changes, get you stronger, more mobile. So even if you do end up needing surgery 6 months, 12 months down the line, you've probably experienced a pretty significant improvement in symptoms, and you've learned a lot about just healthy habits overall. There was also a great study about fear avoidance and how that been played out into outcomes. So avoiding movement because of fear and undergoing physical therapy, which that's another topic I talk a lot about with my patients. So no matter what, you're gonna come out of it with something. You're gonna come out of it with tools in your toolkit for alternative pain management, mobility, exercises you can keep working on. So don't think of it as a waiting period. Don't think of it as that MRI or that surgery is going to be the only thing that helps. I really want people to know physical therapy is a treatment in itself. We have a lot of tools in our toolbox and we love to help you. Thanks for listening today.